Joining me now is the director of the National Institute of Allergy and Infectious Diseases, Dr. Anthony Fauci. Dr. Fauci, good to see you.
Good to be with you. Thank you for having me.
So first, I have a very selfish question. I tested positive for COVID a few weeks ago, and I have been in the house for 17 straight days. And I want to know, do I have your permission to leave?
Well, I can't give you official permission to leave, but when you were first infected, did you have symptoms or were you completely without symptoms? You
I
did.
had symptoms, yeah.
Okay, so if you are 10 days from the onset of your symptoms, which you said you are because it was 2 weeks ago, and have you had fever within the last 3 days?
No, I haven't had a fever in about 10 days.
Right, then you're pretty good to go.
Oh, you've just made my entire day better. One of the reasons why we wanted to talk to you, Dr. Fauci, was because the African-American community has been hit particularly hard by coronavirus. We have disproportionately high infection rates, hospitalization rates, and death rates. Can you help me, first of all, make sense of why that's happening, how we can make up 13% of the country with such a high number of infections?
Yeah, Mark, it's a what I call a double whammy against the minority, but particularly the African American and Latinx community. And that is, you don't like to generalize, but as a demographic group, that the African American community is more likely to be in a job that does not allow them to stay at home and do teleworking. Most of the time, they're in essential jobs. I mean, obviously, there are a lot of African Americans who are not that could just as easily do that. But as a broad demographic group, you're outside, you're exposed. You may be in a financial or economic or employment situation where you don't have as much control over physical separation, which is one of the ways that you prevent infection. So the likelihood of your getting infected is more than the likelihood of someone not in your position. The other side of the coin, and this has a lot to do with long-term social determinants of health. As a demographic group, African Americans have disproportionately greater incidence of the underlying conditions that allow you to have a more unfavorable outcome, namely more serious disease, hospitalization, and even death. That is diseases like diabetes, hypertension, heart disease, obesity, chronic kidney disease. If you look at populations as a whole, and you look at the demographic group of African Americans and the demographic group of the rest of the population or Caucasian, what you see is a much greater incidence. So you have two things going against you. You are physically in a position that's more likely you're going to get infected. And if you do get infected, you're more likely to have a serious outcome. To me, the thing to do is we need to focus and concentrate resources in those areas that are overrepresented by African Americans. In other words, allow you to get tested more quickly, results back quickly, and access to health care. We can do that right now, today, if we concentrate resources.
How do we get the most vulnerable people, particularly poor Black people, access to healthcare, access to preventative stuff? What kind of resources could we redirect?
That's it. What we can do is that there are a number of ways to do that, is to get, first of all, a greater awareness of the need that if you're African American and you get infected, it is more likely you're going to have a serious outcome. So we've got to just get a public awareness on the part of clinics and hospitals that you have to pay special attention, that you have someone at a greater risk. And when you know you have someone at a greater risk, you make certain medical decisions. You maybe get them in the hospital earlier. So we've got to educate people on that. The longer term one is something that you're not going to cure overnight. And that is the economic and other conditions that African Americans find themselves in, that they're not in a situation where they can have a greater access to health care from more of an economic standpoint. But the other thing that I think we need to make a commitment that goes probably measured in decades. And that is, why do African Americans have a greater incidence of hypertension? Why do they have a greater incidence of diabetes? Why do they have a greater incidence of obesity? It's not genetic. It has to do with years and years of access to the right kinds of food, access to the right kind of health care. Those are the things that we've got to change. But that means that perhaps if there's one silver lining in this outbreak, which I hope there is always some silver lining in everything that's so challenging as this, is to focus with a laser beam on the disparities in health that we've got to change. And it's got to change at the fundamental basic level. It's not going to be tonight or tomorrow or next week. It's going to be over the next several years.
Are
So,
you?
and I hope when people think about this outbreak, they say, hey, let's pay attention to this, because it's another example. I went through the same thing early on in the early years of HIV. The disproportionate number of African Americans who get HIV infection. There are 13% of the population, 45% of all of the new cases of HIV are among African Americans. That's unacceptable. That's another example of the unfortunate disparity of health.
Talk to me about the fall. There are many of us who are very concerned about what the fall is going to look like. There have been different messages at different times over the last 3 months about what the end of the summer and the beginning of the fall would look like. Some said the numbers of infections would drop. Others said they would spike. Based on the best information we have now, what should we anticipate between now and, say, November?
You know, if we had gotten our infections down to baseline, and I'll explain what I mean by baseline, then this would be a more relevant conversation. But I'll explain why it is still relevant, but it's in a different track than you think. So if you look at the European countries, or even some of the Asian countries, they had their peak, and when they came down to a real baseline, so that they had maybe 10 or 100 new infections per day. We went up and came down to an unacceptably high baseline of 20,000 cases per day. And right now, as you and I are speaking, the surging of infections that we're seeing in Florida, Texas, Arizona, California is making it go up to 40, 50, 60, and 70,000 cases a day, which is really not good at all.
Yeah.
The reason I bring that up is that if we went down to baseline, you could say, well, that's the first wave. Will there be a second wave as we get into the winter when people congregate inside? You have circulating of air, you have cold weather that viruses like better than hot weather. Then you could be concerned, well, what's going to happen when that happens? But right now, unfortunately, we're still knee deep in the first wave. We haven't even gotten out of it yet. So my concern is that if we stay at this high level through the summer months, which I hope we don't, but if we do, when the fall and the winter comes, it's going to be complicated by the onset of the influenza season. And influenza is another respiratory illness. So you may have two co-circulating respiratory illnesses, COVID-19 and influenza.
Can they be compounded, doctor? Like, is it possible for someone who's currently carrying the flu to also get COVID-19? And if so, do they double down and do more damage, or do they offset?
We don't know that because it hasn't happened yet. So we don't know that. But it just makes diagnosing and taking care of people that much more problematic, because we have two circulating respiratory illnesses at the same time. So what I would hope happens, and we're struggling to make this happen, is that our baseline continues to go down instead of going up. The problem is our baseline is going up with the new states that are getting infected. If we can get it down to a very low level, we'd be much better prepared when the fall and the winter comes, so that when you get these blips of infection, you could suppress them much more easily, as opposed to starting off at a very high level.
Right. Well, Doctor, part of why we're seeing this spike is obvious to everyone, uh, is that more people are outside, more people are congregating, as you pointed to, but that seems to be directly connected to the states that are quote unquote opening up. And
Right.
so, if people can go to bars, if they can go to restaurants, if they're hanging out at pool parties, if they're sitting inside at restaurants, these are all things that make all of us more susceptible to infection. Is there any way to get to a reasonable baseline if states keep opening up?
Okay, that's a great question. The answer is yes. I believe if the states, the cities, the counties follow the guidelines that we, and I was very much involved with this, the guidelines for opening America again, they're very clearly delineated. And what it says is that you have a gateway. So you've got to prove in your community that the cases are going down over 14 days. Then you go to phase one. If you're successful in phase one for a certain period of time, you move to phase two and you gradually open up. So, what has happened to create these surges? First, some states did not pay attention to the guidelines. They jumped from one phase to another without gradually and prudently trying to go in a very measured way to open. Point number two, some states that professed to do it correctly, the people in the states, particularly young people who feel invulnerable, said, what the hell? It's unlikely I'm going to get any symptoms. So who cares? So what they do, they don't wear a mask. They go to bars. They congregate in crowds. They have the kind of parties you say. And that's what leads to the surge. So if you want to open, and I said this many times, instead of making the public health measures the obstacle to opening, make the public health measures a vehicle or a roadway to opening by doing it carefully and in a prudent way. The only unfortunate thing is we haven't done that.
How then do you feel when there are governors of states who are trying to open things up in ways that do position public health considerations as an obstacle? I mean, from politics aside for a minute, when you hear a state say, "Hey, we're keeping the bars open," when you see people fighting to sit inside of restaurants, knowing the dangers, how do you feel about that?
It's very frustrating, Mark. It really is because I see what happens when states, cities, and communities do that. It's inevitable what happens when you do that. I mean, it was very frustrating when we started the opening America again and we had the guidelines that we were hoping that people would actually be adhering to the guidelines, and they weren't. You know, there are maybe 4 or 5 fundamental principles that everyone should be doing right now when there is activity of virus in your community. One, wear a mask at all times. Number two, do not congregate in crowds. Number three, keep physical distancing. 6 feet from someone, you should be wearing a mask. Close the bars. Bars are a hotbed of transmission. And then practice personal hygienes, washing your hands as often as you can. That's not rocket science, Mark. That's pretty simple. You could still open up your community. You could still get economic recovery while you're doing those things. And yet, some people feel that if you're going to open up, you've got to let all caution to the wind.
So, what do you say to like the governor of Florida or the governor of Georgia when they do, at the very least, defy the principles you just laid out? Have you been in conversation with them? I mean, how do they make sense of this to justify this?
Okay, so about an hour and 5, 10 minutes ago, I was down at the White House on a governor's call saying to them exactly what I just said to you, almost word for word, almost word for word.
And are they?
Well, we'll see. We'll see what happens.
Are you optimistic that Florida and Georgia in particular will be responsive to your warnings?
I hope so. I know that Dr. Birx, Debbie Birx, my colleague on the coronavirus task force, has traveled down to several states over the last couple of days. The vice president has been down in Florida yesterday. So we're all trying to push the envelope here to get these things done, and hopefully they will.
Okay. One of the things we talked about was the fall. In the African American community in particular, uh, particularly in urban communities, a disproportionate number of the children are going to public schools. They're not going to private schools that have, Zoom classes, 2 or 3 days a week. They're being asked to go back to school, sometimes 5 days a week, in some cities, 2 or 3 days a week, but they're returning to school. There's been a federal push from the Secretary of Education on down saying, hey, we need to reopen schools and get kids back in the school building. Based on everything you just told me about the danger attached to this, about young people spreading the disease, is it wise to open schools?
Well, I will answer the question directly, Mark, but let me just frame it a little bit differently.
Okay.
Given the unintended downstream ripple effect negative consequences of keeping children out of school, as a default position, 40,000 feet, we should try as best as we possibly can to get the children back to school and to keep children in school. However, and I want to underline however, the most important thing that must be paramount is the safety and the health and the welfare of the children, of the teachers, and of the parents of the children. So if you can get the children back to school and do things in a way that's safe, you should try as best as you can, because we live in a big country that's very, very heterogeneous with regard to the level of virus. So there may be some counties, some cities where the level of virus is so low that with impunity you could bring the kids back to school and not worry about it. There are going to be some in which the level of virus is so high that might be impossible to do. And then impossible because the teachers wouldn't do it and the parents wouldn't do it. So forget about what you're recommending.
But your recommendation is important. So
yeah, but let me finish.
Oh, please.
But there are areas in between where there's enough level of infection where you just don't want to blow it off and say, we're not worrying about it, that you can do things, a hybrid model, part of it being online, part of it being present, alternating days, morning, afternoon, wearing masks for the students that can do it, having the teachers wearing masks. All of these things are being discussed at different levels by principals and superintendents. Having said that, you don't want to put the kids in danger. So you want to try your best to open the school, but always be sensitive to the safety of the children.
So then the idea of targeting areas and being responsive to the specific conditions of a city makes sense to me.
Yes, absolutely.
But what the federal government is saying right now, at least this Department of Education and Secretary DeVos is saying, is we want them all open.
Yeah.
Would it be fair to say that you would not support that decision to open all schools?
Yeah, the trouble is, Mark, it'll be a soundbite if I say I support and don't. But let me tell you, and then you could come to your own conclusion.
Okay.
You've got to be open-minded and flexible so that if you're in a situation in which clearly the children's health and welfare is going to be compromised and in danger, you should act accordingly. And okay.
I like that answer. You're getting good at this.
Yeah, I've been at it a long time, Mark.
Are there any targeted efforts in our community around proper testing, around what to look for in terms of symptoms, in terms of preventative measures? Is anything being targeted to the African American community right now?
The CDC apparently is doing that, not my institute, because mine is a research institute.
Right.
But the CDC is doing that. I tell you one thing we are targeting in the African American community is, we made the announcement yesterday that we started a phase 3 trial in a vaccine, namely a vaccine to determine if it actually works. We want to make sure that since African Americans are among the most vulnerable of getting infected and of getting a bad outcome, that they are properly represented in the clinical trial. So you don't have a clinical trial that you're gaining information only on white people, because then if you start to administer it to African Americans, you won't know whether it works as well in that group or whether it's as safe or not in that group. So we are trying now to target to make sure that there's proper representation in an equitable way, not only in the vaccine trial, but when the vaccine gets approved, which I think it ultimately will, that it is accessible to the African American community so they can get it as easily as someone, for example, in the white community.
There's a long history of skepticism, healthy skepticism, and reasonable wariness of the American medical establishment in the African American community, right? I mean, whether it's the Tuskegee experiment, whether it's our inability to access pain medications at the same with the same pain levels as our white counterparts in hospitals and emergency rooms. I mean, we've had very bad experiences with American medicine for hundreds of years. Uh, a whole bunch of Black folk don't want to get this vaccine. Some are scared of the idea of it. How do you take that into consideration? What kind of steps are done to recruit people for these trials? What do we do?
No, great question. And we, in fact, are addressing that. You are absolutely correct. I mean, we have a history that has gotten much better recently, in the last few decades, but a bad news history going back to things like Tuskegee. And also, I think it's good that you made that comment about pain medication. It's true. I mean, we have African Americans who have sickle cell disease who come into the emergency room in terrible pain. And, there's sometimes a reluctance to give them the pain medication that they need. So those are the kind of things that it's understandable why there's skepticism among African Americans regarding the typical classical medical establishment. So what are we doing about it?
Right.
It's called community engagement and outreach to the community, where we are leveraging the community relationships that we started years ago with HIV, something that I started when I started the HIV program at the NIH, that we developed relationships with community reps who were trusted by the African American community because they were reflecting the African American community. So I often joke, but it's the truth. You want to go into the African American community with people who look and think and act like the people you're trying to convince. You get a white guy with a suit like me and a tie on going in talking to people who are people that you don't usually relate to every day. But if you get the community people on the ground to go in and say, hey, let me tell you, I've scoped this out. This is something for your own benefit. In addition to people like myself saying the same thing. So when you see people in authority and people at the community level saying the same thing, hopefully you can get the African American community to essentially do things for their own benefit, because it's for your own benefit to protect yourself from this infection.
Your best guess, let me not use the word guess, your best informed analysis.
There you go.
Suggest that a vaccine will be completed when and available for mass consumption when?
Okay. So we started the phase 3 trial yesterday. It's going to take several months before you determine whether it works or not. You can't guarantee that it will be effective. We're trying to find out if it's safe and effective. We should know that by the end of this calendar year, sometime in November or so. How do we believe that, or do we believe it would be effective? I think if you look at the early results from the phase 1 trial, I can say, although I can't guarantee it, because you never can guarantee anything with vaccines because of the vicissitudes of whether or not it's going to be effective, that I can say that I am cautiously optimistic that we will have a vaccine that will be available by the end of this year, the beginning of 2021. When will we have a situation where we'd be able to distribute it in a meaningful way? I think somewhere into 2021, we might have a vaccine.
And
again,
like first quarter?
I hope so. I think you're going to have maybe tens of millions of doses by the first quarter. I don't think you're going to have enough for the entire country in the first quarter. But I think by the time we get to the end of 2021, if the vaccine is successful, and I always say if because you never can guarantee, if it is, I believe as we get well into 2021, most people can wind up getting vaccinated.
Doc, you've been here for many decades now, and you've served under 6 presidents. Has your position ever been more political than it is right now?
Um, Probably not. And it isn't that my position is political, Mark. My position is a completely apolitical position. I'm not a presidential appointee. I'm a civil servant. I am not a political person. I don't ever have any ideology. It's all scientific.
Yeah.
However, am I operating in a political environment? Wow. Yes, of course. And it isn't just me. It's look at the country. I mean, I'm sure it's impacting you. I mean, we live in a very divisive situation. I've not seen the political parties be so split in the kinds of things that they're standing up for. I mean, we've had political disagreements in the past, but never the degree of divisiveness as we're seeing right now.
I guess in the years that I've followed your work, and I followed it for quite a long time, I've never heard your office maybe not be political, but certainly be politicized in the way that it has been. I heard an interview with President Trump, or a tweet rather that he sent out, where he said that you were misleading the American public, and I heard you respond and say you weren't. What do you think he means by that?
Can't say, Mark. I don't know. I mean, I just don't know why that happened.
Did you ask him?
When I'm with him, I have a very good relationship with him. And then I see something like that and I scratch my head and say, how did that happen?
Is that a common thing where you talk to him, you think things are okay, and then you look on Twitter and think he...
No, I do think in reality, Mark, that things are okay. But, I've never been able to understand the tweet culture.
It's a fascinating thing. I know you say you've never misled the public, but one of the things I don't even challenge you on that, but the president did point to on a Fox News interview the number of times you've been wrong. He said,
Right.
Wrong on masks, wrong on.
No.
What do you say in response to that?
I haven't been wrong. Period. I haven't, and I'd be happy to go through each and every one of those. And the reason is, what gets missed in this mix, Mark, is that when you have an evolving situation like this outbreak, it is brand new, virgin territory, uncharted water. And when you're dealing in the arena of science, you collect data and information to the extent that it's available to you. And you must act at the time on the basis of the solid scientific data and information that you have. As the situation evolved, and it is a moving target. Remember, we've only been doing this for about 5.5 to 6 months.
Yeah.
As the time goes by, you get more information and more evidence that in fact changes the opinion and the recommendation that you might have.
How about masks, though?
Same thing. That's a very good example, because in the beginning, the situation was that there was a very difficult shortage of PPE and masks for the people who needed it. So we were told at the task force that the people who needed it, like the healthcare providers, were not able to get that. So we did not want to tell everybody, go out and get a mask, and then we wouldn't be able to have it for the people who are putting themselves at harm's way. So that's why.
But doctor, is there a difference between saying a mask will be great, but we don't have enough, and saying you don't need a mask?
No, we were saying don't go out and buy masks. But then the utility of a mask at the time in January and February, people forget. But it was thought that this virus was not easily transmissible yet, only when it became community spread did we think. The other thing that we didn't know is we didn't know that there would be 20 to 40% of infected people would be without symptoms. And the other thing we didn't know is that there was a lot of transmission from an asymptomatic or pre-symptomatic person to another person. We did not know that back then. As soon as it became clear that, in fact, a lot of transmission was by people who were walking around innocently thinking that they were not infected, and they were infecting other people. So when we got that data at the same time as it became clear that there was no shortage of masks anymore, that we made the recommendation, wait a minute, We don't have to conserve the masks. And my goodness, there's a lot of transmission by people who are walking around thinking they're okay. So the mask that we recommend is more to prevent you from infecting somebody else than it is to help you to get protected from someone else. So way back then, we didn't know that. And that's when we made that recommendation. As soon as we found out that the scientific evidence indicated we really should be wearing masks, that's when we recommended it. So it wasn't wrong at the time. It was the best thing to do. But as things change in science, you have to be humble enough and flexible enough to change your recommendations.
And I just have one more question for you after this, but has the White House been willing to go with that flexibility? When you say to the White House, hey, this was the best information I had, now I got better information, how do they respond to that?
You got to be careful. The White House is a big place.
Well, let's talk about the president.
No, the president right now and I, we're fine. We're fine. There were people in the White House who came out with a list of things that they said were misleading, and that is not helpful. And I could counter every single one of those things.
That must be frustrating, the fact that you and the president, as you say, are good. You see the tweets. You have sources coming out from the White House saying he's doing a bad job. People saying he's misleading the public. He's mismanaging this. And I know you hear it.
Yeah, but Mark, let me tell you something that could settle this whole discussion. That's noise, Mark. That's noise. You know what reality is? Reality is trying to do our job to protect and preserve the health of the American people. That is my job. To be honest with you, Mark, I could care less about that other noise. Wow. That just is a distraction. I know what I need to do, and my colleagues on the task force know what we need to do. So if you have a couple of outliers saying a bunch of stuff, to be honest with you, you may not believe it, Mark, but I don't even pay any attention to that.
You are a better man than me. My last question for you is something that has been trending for the last day or so. Hydroxychloroquine has been trending like crazy. There's a viral video going out by a Dr. Stella Emanuel, a pediatrician who's now based in Texas. She says, when was the last time Dr. Fauci had a stethoscope to a patient? That she says she's treated 350 people with, I believe, a Z-Pack, Zithromax, is that right? Zinc and hydroxychloroquine. And she said that no one's died. She's treated hundreds of patients. They've all survived, and that it effectively works. She says double-blind studies are getting in the way of the need to actually treat patients immediately. Okay. What do you say to them, to her, and to that movement?
Well, to say that double-blind placebo-controlled trials are getting in the way is I mean, give me a break, Mark. Give me a break. Okay, enough said.
But that is like, because that's the easy part, right? We all, and for everyone out there, yes, we want scientists to do science. We don't.
Yeah. In other words, what they're saying is, why are you believing scientific evidence?
But I have these anecdotes.
I know what works.
Right.
I mean, really? Is that what you're saying?
But they're making a bigger point, whether you agree or not, is the question, which is they're saying, look, there's reason to believe hydroxychloroquine works, that big pharma's getting in the way, and that we are ignoring something that could help save people now. What do you say to that claim?
To that claim, Mark, you say what you should say, that multiple trials that were well conducted have shown that hydroxychloroquine is not effective in coronavirus disease. And all you need to do is look at the evidence. So what you're trying to say is, there's all this evidence. Don't look at it. Listen to what I say. No, when evidence comes up, if it does, and Mark, it might, if evidence comes up in a trial that under certain circumstances, maybe early disease, I don't know, in certain circumstances, if evidence comes up in a well-controlled, placebo-controlled trial that any drug, including hydroxychloroquine, works, I would be the first one to admit it. But the scientific evidence that has accumulated to the point where the FDA has withdrawn their emergency use authorization for it, I will always go with the scientific evidence. Whether it proves it one way or the other, I will go with the scientific evidence.
And this anecdotal stuff is just coincidental? Do you think they're being misleading? Do you think it's just that, hey, I don't. If anybody's zinc in time, they'll survive, under certain circumstances? I mean,
Mark, I don't even want to comment on that because I gave my answer by saying you got to do the scientific evidence.
all right, that's fair. Well, doctor, I want to thank you for your time. I hear, and this is just a rumor, but I hear that my city, Philadelphia, the Phillies, are looking for a relief pitcher. Could I convince you to leave the institute and maybe join the bullpen?
If you want to see the Phillies win, you don't want to do that, Mark.
Doc, thank you so much. Good to see you.
Yeah, same here as always. Take care of yourself.